Okay. Yes, yeah. You're live now. Okay. Okay. Idalia. So this is the place to be so that you'll be in the camera. Okay, don't go farther away. Okay. Should be within the frame. So do I have to keep this or I have to put it on? No, it's a lapel. Okay. I'm gonna tell them to. Yes. 2 minutes. 2 minutes. So you're the timer too? This is the timer. Okay. Okay. All right, you guys. So here's the deal. I introduce you. You get the microphone. Tell them to give you the microphone. You're done. Whoever's done, you give me back the microphone. I introduce the next one. I'll give you the microphones. It's gonna be a flow of microphone, you and me, you and me. Yes. After you're done, give it back to me so I can introduce the next one, and then I give it to the next. Okay. We good? So let me know, sweetheart, if we're good. Are we already starting? Okay, 6 more. All right. You're my cue. You tell me when it's time, right? All righty. Good morning and welcome to the Capstone presentation of our senior students' proposed study of their chosen topic. This is the pinnacle of their years of knowledge acquisition here at SEU and finally prove that they're ready to face the challenges of the world with their bachelor's degree. So let's get started. Our first presenter is graduating with a degree in biology with a concentration in medical sciences. She's from Fort Myers, Florida, and has been at SEU for 4 years. She has served as a teaching assistant, a site peer mentor, tutor at Crystal Lake Elementary, health services volunteer, has been a part of honors and the track and field team here at SEU. Very busy. After graduation, she plans to take, I just got the term, an enhancement year from Dr. Franklin to work as a medical assistant at a dermatology office, then attend PA school. Her goal is to practice as a PA in oncology. Ladies and gentlemen, please welcome Ms. Idalia Romero Talbert.
Hello, everybody. My name is Idalia Romero Talbert, and today I will be presenting my capstone titled, Is Nicotine a Viable Treatment Option for Cancer-Related Cognitive Impairment? So before I begin, I'm just going to be giving you guys an outline of everything we'll be going over today. So first, I'll be talking about cancer-related cognitive impairment, giving some background on that, a background on what nicotine is. I'll be going into my specific aims, and then my conclusions, acknowledgements, references, and there will be time for questions at the end. So what is cancer-related cognitive impairment, or CRCI for short? To begin, it is a group of cognitive impairment symptoms that affect many cancer patients worldwide. The incidence is in a range from 16 to 75%, and it is caused by the continuous treatment of a malignant tumor or cancer. The symptoms of CRCI range from mild to moderate. In this image, you can just see the complexity of CRCI and how there are so many factors that go into its development. So, cancer-related cognitive impairment, what made me get into this and what made me want to study it? So, my freshman year of high school, my dad was diagnosed with a really rare cancer called blastic plasmacytoid dendritic cell neoplasm. Now, it sounds like a lot of words, but basically it's a mixture of leukemia, lymphoma, and skin cancer. So because of this, he had to undergo extensive chemotherapy treatments and even get a stem cell transplant. Without the stem cell transplant, the survival rate was 0%. With the stem cell transplant, the survival rate was only 10%, so by God's grace, he's still with us today. As a result of all of these treatments and the stem cell transplant, he ended up with CRCI. So this is what really makes me believe that there's a critical need for there to be extensive research to find a treatment for this impairment, as it really does affect everyday living for these patients. Okay, so to start off with the symptoms of CRCI, there are a wide variety, but I'll just be going over a few. So to begin, an impairment of memory is a really hallmark feature of CRCI. When I say memory, I'm talking about short-term memory, as long-term memory typically is not affected. So for example, if you schedule a doctor appointment on Monday, on Wednesday you might be, who did I schedule my doctor appointment with? What time is my doctor appointment? Things of that nature. There's a slower comprehension speed found with CRCI, as well as trouble concentrating, difficulty with word retrieval, and difficulty multitasking. So the affected population of CRCI. I have broken this up into different groups, starting with the age group. Typically, those affected by CRCI are either childhood survivors or the older survivors of cancer. So in children, the incidence rate is in a range from 6 to 68%, while in adults, it's from 1 to 75%. The type of cancer also plays a role in the development of CRCI. So there's a common occurrence of this when there's a prior incidence of Hodgkin's lymphoma, leukemia, or a cancer that has a low survival rate. For example, my father's, which had a really low survival rate. There's a higher incidence in survivors of breast or gynecological cancers in comparison to those who have testicular cancer. This leads me into my next group, which is gender. There's a higher occurrence of this impairment in females. And also, there are different comorbidities that lead to the development of CRCI. So if one struggles with fatigue or mental illness, such as depression or anxiety, there's a higher incidence of this, as well as the occurrence of diabetes or asthma. So let's go into the detection of CRCI. There are a couple of neurological assessments that are used to detect this. Now, it's important to note that the symptoms of CRCI are fleeting, so it's important to conduct these assessments over a long period of time so that it's easier to detect its occurrence. Current treatments. There currently isn't a cure for CRCI, so there are different ways that healthcare providers try to treat their patients and have them have the best quality of life possible. So this has been broken up into physical and behavioral treatments. So we're just going to start off with physical. So as common in most health conditions, exercise is a way to improve the symptoms of CRCI. Another way is by doing whole body resistance training. Now this can be weight training or training that uses resistance bands. On to behavioral. Cognitive behavioral therapy is something that has been found to help with the symptoms of CRCI along with education. Now, education is something that I think is really important to take into account here. So when my dad was first diagnosed with cancer, we had no idea that CRCI was even a possibility. His doctors didn't mention it. We only knew that it was a thing when he started experiencing symptoms. When he was at work, he was a teacher before, and he was having trouble with his lesson plans, didn't really know what was going on. So he went to his doctor, and the doctor was like, oh yeah, that's CRCI. So it's kind of crazy that after the fact, that is something that we knew about. So it's important to educate patients when they are diagnosed with cancer so that when they start experiencing symptoms, they can become treated from the beginning. Cognitive retraining is also something that is used to treat CRCI. So now that we've gone over CRCI, let's dive into nicotine. Now I know when I say nicotine, everyone thinks this. I am not talking about everyone smoking vapes. That is not what I'm saying. I am talking about the use of nicotine, the chemical itself that comes from the tobacco plant. So nicotine acts like an agonist in the brain, so it initiates a physiological response when combined with a receptor. It acts as an agonist of nicotinic cholinergic receptors, and these receptors are in the central nervous system and the peripheral nervous system and are stimulated by nicotine or acetylcholine. This stimulation leads to the release of neurotransmitters such as dopamine, serotonin, and glutamate. All right, so I know that when we think of nicotine, we typically think of smoking cigarettes and how that can be carcinogenic, but there are actually positive effects of pure nicotine itself. Some of these include, so in animal models, nicotine has caused an improvement in memory and learning, and in humans, there is an increase in attentional performance. It positively impacts response time as well. And there's also current research that shows that in Alzheimer's patients, nicotine has led to improvements in visual and formation processing. Nicotine also affects more than just cognition. So it can reverse network alterations that are found in depression. So there's research that shows that it could potentially lead to improvements in depressive symptoms. There's an agonist of nicotinic acetylcholine receptors, as said before. And in this image, you can just see the complexity of the nicotinic acetylcholine receptor and everything that it can impact in the brain. All right, so modes of nicotine delivery. We all know that there are a lot of different ways to ingest nicotine. Some of these are through nicotine gum, nicotine patches, microtabs, lozenges, inhalators, and nasal sprays. I think that this is really cool because then a patient, if nicotine is found to be effective in treating this, they can choose the mode of treatment that they would like. If they want to just slap a patch on their arm, that works for them, or if they just want to pop a nicotine gum, that works for them as well. So now that we've gone over CRCI and nicotine, let's link them together. So it is found that drugs that enhance nicotinic cholinergic systems in the brain lead to cognitive enhancement. And as we've talked about before, nicotine does this. So when there's impaired cognitive performance, this is important. So I'm not saying that nicotine can help all of us with cognitive function. Nicotine is only effective in those who have lower cognitive performance. So is nicotine a possible treatment option for cancer-related cognitive impairment? This leads me into my specific aim 1. My first specific aim is to investigate the effects of nicotine administration on the symptoms of CRCI via gas inhalation of nicotine. I hypothesize that if nicotine is administered through gas inhalation to cognitively impaired mice, this will lead to an improvement in their cognitive impairment. The population of mice that I will be using will express the apolipoprotein E3 gene, which is found to be the most genetic risk factor in developing CRCI. I will be using 60 adult-aged female mice, and they will all be housed under the same conditions. Okay, so for my experimental group, it will contain 15 mice. They will go through the Barnes maze, which is a maze that is used to test spatial learning and memory. After this, they will be administered doxorubicin hydrochloride, which is a common chemotherapy drug that is used today. Then they will go through the e-vape self-administration paradigm, which is to model how nicotine is used in humans in the real world. And then 6 weeks after the chemotherapy administration, they will undergo the Barnes maze again to test if their cognitive function has improved since the nicotine administration. This is an image of the Barnes maze. So this is what the mice will be going through before and after the chemotherapy and nicotine. And I expect that the inhalation of nicotine gas for these cognitive impaired mice will lead to an improvement in their cognitive function. Now for my control group, they will also be going through the Barnes maze, but instead of being administered chemotherapy, they will be administered saline solution. This is to show that they are not cognitively impaired and to show that nicotine does not have any effect on mice that are not cognitively impaired. I expect from this that their cognitive function will be unchanged since they will not have any chemotherapy administration. Going into my second specific aim, so for this, I will be investigating the effects of nicotine administration on the symptoms of CRCI via intraperitoneal injection of nicotine. Through this, I hypothesize that there will be an improvement in cognitive function in these mice. They will be going through the Barnes maze, administered the chemotherapy drug, but instead of the gas inhalation of nicotine, they will be administered the nicotine intraperitoneally. From this, I expect that they will experience an improvement in cognitive function. Then my control group will undergo the same as in specific aim 1, and I expect that their cognitive function will not be changed due to the fact that they have not been administered chemotherapy. So now to my conclusions. If this is successful, I hope that it would improve the quality of life of cancer patients that are living with CRCI worldwide. Some limitations of my study are that in my first specific aim, it might be seen as a limitation as the nicotine is self-administered. However, as I said before, this models the use of medications in the real world. I know some healthcare providers sometimes encounter patients who are not willing to take their medications when they're supposed to, so this kind of models that. And also the side effects of nicotine are a limitation. For future studies, I would like to investigate eradicating these side effects and also the effects of prolonged nicotine consumption. For my acknowledgements, I would like to acknowledge God, for we wouldn't be here without him. I'd like to acknowledge my advisor, Dr. Franklin, for all of her help, our professor, Dr. Abraham, my family and friends, and my peers. Here are some of my references, and thank you guys so much for listening. Yes.
My question is, you had them doing the maze before they started the treatment for the chemotherapy, and at the end, why not also before they started the nicotine?
That's a good question. I would just say that it was before giving them anything, just to give like a baseline of their cognitive function before they are administered anything, just how they are naturally.
I wonder, how do you know they even had the cognitive impairment? Did they do the maze to do that?
That's a good point. That's definitely something that I would put into my future research. Yes.
So nicotine is always in the tobacco, as we already know, and inhaled, right, part of the smoking process. So how soluble is nicotine if you put it in IP rather than having it smoked, right? I mean, one of your aims is actually to put it as like a smoke. So what would be the difference, essentially? Like there should have been a study already, right, as far as solubility, or why is it that, is it more, I guess the question, is it more effective when it's being inhaled rather than when it goes to the blood?
Right. So are you kind of asking like on the potency of the nicotine, I guess?
Yeah, like how is it going to be more effective going into the brain cells, right? When it's being inhaled rather than when it's insoluble in the blood.
Right. So that's what I hope to find in this research. That's why for my first specific aim, it's the gas inhalation, see how effective that is. And then for the second specific aim, it'll be injected intraperitoneally. And then if there is, better cognitive like if they score better on the Barnes
So
maze
there's
in the
no
first.
study at all
No,
about
no.
nicotine solubility and
Oh, I'm sure there is,
efficiency
I
of
guess.
yeah, that's the question.
Right. I didn't really do too much research on that, but it's definitely something that's important. Yes, Hunter. I chose this one just because it's commonly used to treat patients with cancer. So I didn't want to just focus on like the most effective chemotherapy, for example, just something that is used worldwide or used most commonly, because this is something that can affect any cancer patient, no matter if they have a cancer that is easily cured or one that is really hard to cure. Yeah, I'm not sure if the chemotherapy itself plays a role in that, which that probably is something that would. But I know that there are a lot of different factors that go into its incidence, such as, like I said before, diabetes, asthma, if you struggle with anxiety or depression, stuff like that. Pedro, I guess.
So, I have a question regarding the mindset model
Mhm.
that you're using, a model of CRCI at the beginning of the study.
No, so hopefully with the administration of the chemotherapy, that would model the chemotherapy-induced impairment. I think there was another question. Oh.
Thank you. That was a wonderful presentation. All right, now moving on to our next presenter. She is graduating with a degree in biology with a concentration in medical sciences. She's from Pomfret, Connecticut. Did I say it right? Yes. Okay. She has been at SEU for 4 years. She has served as an Aventura RA, another busy one, first year experience, academic student leader, Link residential mentor, TA for CNHS, SEU house group leader, health services volunteer, made the dean's list, and was a member of PHSO. After graduation, she plans on attending PA school at Massachusetts College of Pharmacy and Health Sciences. Please give it up for Ms. Alyssa Mawson.
It should be on Abigail's drive. Hello, everyone. My name is Alyssa Mawson, and I'm going to be talking to you about increasing the efficacy and use of the abortion reversal pill. A quick outline of what I'm going to be talking about is a little background on what an abortion is, and then give a little overview of the current reversal process that exists now. I'm then going to go into my aims and methods, talk about expected outcomes, and the impact that this will have on society. So what's an abortion? Well, abortion is the termination of a pregnancy. For my study, I'm going to be focusing on a medical-induced abortion. This is not labor induction, not dilation and evacuation, not Plan B, and not vacuum aspiration. It's a medical-induced abortion that is prescribed from a physician when a woman decides that she wants to abort her pregnancy after she's already found out she's pregnant. This occurs in the first trimester and is often approved up to 10 to 13 weeks of pregnancy. However, the laws differ drastically per state. So what's a medical-induced abortion? Well, the medical-induced abortion takes place in 2 separate pills. The first pill is called mifepristone. Then, 24 to 48 hours later, The second pill is taken, misoprostol. This then leads to the pregnancy being terminated. But what exactly do these pills do? Well, mifepristone blocks something that's called progesterone. Progesterone is released from the corpus luteum, and misoprostol then is taken, which causes the uterus to contract and completely be empty. But what's the big deal about progesterone? Why do we care if mifepristone blocks it? Well, progesterone is a steroid hormone. It is, again, released from this corpus luteum and increases implantation proteins as a whole so that the baby or the embryo at this point can implant into the uterus. It provides the fetus with the oxygen and the nutrients that it needs from the mother. However, when it's blocked, it leads to what's called decidual necrosis. This is when the endometrium starts to shed, and it can also lead to uterine contractions. It leads to softening of the cervix and cervical ripping. This in total leads to detachment, expulsion, and in total an abortion. As mentioned, this progesterone in a normal pregnancy binds to its progesterone receptors. But in an abortion, when that first pill is taken, mifepristone, it has a greater binding affinity for these progesterone receptors than progesterone itself, causing progesterone to be blocked from getting where it needs to be. And then 24 to 48 hours later, that second pill is taken, misoprostol, which causes the uterus to contract and the abortions to be complete. Now, what if a woman's deciding to go through with this, but then changes her mind? What if she doesn't want to abort her baby anymore and is wondering if there's a second chance at choice? I'm going to talk to you about this reversal process and explain what currently exists. As I mentioned, there's this progesterone receptors. In normal pregnancy, the progesterone can bind to it. But in an abortion, when that mifepristone is taken, because of the structure of it, it has a higher binding affinity for this progesterone receptor than progesterone itself. However, this reversal pill is more progesterone. The idea behind it is that it can outcompete this mifepristone and still bind to the receptors, giving the baby what it needs from the mother. And you might be saying to yourself, well, I don't understand. If a woman's going through with an abortion and deciding to get one, why is she going to change her mind? Well, there's a lot of realities of pregnancies that we need to discuss. When a woman finds out she's pregnant, sometimes there's a lot of fear involved. There can be shame, pressures, uncertainty, impulsivity, and tons of hormonal imbalances that impact cognitive decision making. That often a woman just decides, well, I guess I'll get an abortion out of panic. This is why there's a need for abortion pill reversal and currently a hotline number that exists now. Every single baby that you see on this screen is alive today because of this pill. And every single woman has gotten to be a mom because she got a second chance at choice. This hotline gives access to over 1,000 healthcare professionals that have 24/7 availability to prescribe women this pill. This pill is progesterone. It's again taken 24 to 72 hours after mifepristone, and an ultrasound would be done immediately. There's no negative side effects known to the baby since progesterone's been used in pregnancies for almost 50 years. And currently, there's a maximum of 64% success rate. You could be saying to yourself, well, that's pretty high, right? Well, there's a big problem with the current reversal process. In order for a woman to actually get access to that pill, there's tons of barriers and obstacles that she has to get through. First, she has to consciously decide she wants an abortion to reverse it. And then she has to call the hotline number, find availability that works within her schedule and her medical providers, find transportation and find money to get to a physician, and then get access to the pill. Who's saying that all women have access to this money and this transportation to get them that? And this all has to be done with those realities of pregnancies that we've already discussed previously. All of those hormonal imbalances and impaired cognitive decision making. As well as hard as that may seem, there's also has to be done in a critical window of time. There's a short amount of time where progesterone can outcompete mifepristone before it's too late. That is why there's such a need to get this pill as soon as possible. Currently, it's not easily accessible, there's not awareness about it, and it overall needs to be more effective. There needs to be more progesterone absorption, and more lives need to be saved. I'm proposing a new reversal process. What if an abortion pill was prescribed, well, the reversal pill was prescribed with a vaginal suppository of progesterone? I'm predicting that both of these together will increase the progesterone so much that it will lead to more live births. I'm also predicting that what if these abortion pills that are prescribed are given at the same time about reversal pills, providing an on and off switch together. My predictions with both of these is that there will ultimately be an 85% increase in live births or higher from that original 64%. This leads me to my specific aims. I really do want to determine if that oral progesterone combined with a vaginal suppository will have a greater effect of reversing the effects of mifepristone in a medical-induced abortion compared to just the oral dose alone. My hypothesis is that it will be more effective and ultimately lead to live births, which is how the results will be determined. My methods will include women who are wanting an abortion reversal and have called that reversal hotline. It will involve two groups. There will be an experimental group, which will consist of women receiving an oral dose and the vaginal suppository together. There will then be a control group of women who are just receiving that oral dose. Throughout their 9 months of pregnancy, they will have a contract agreement that they will sign to inform researchers throughout the pregnancy. They will agree to attend follow-up ultrasound appointments, and their variables will be noted as well. These variables will include if they've had any prior pregnancies or prior abortions. Their pregnancy and birth will be tracked, and in total, this will be a 4-year study. Throughout the 4 years, all of the data will be collected and analyzed. This leads me to my second aim. I want to determine if there will be an increase in live births if the abortion pills are prescribed at the same time as the reversal pills when a woman is seeking an abortion. My hypothesis, again, is that if they are given this on and off switch together, that there will be up to an 85% increase in live births, and ultimately more lives will be saved. This number is how the results will be determined. This will be done through women who are wanting an abortion. There will be an experimental group consisting of the abortion pills, mifepristone and misoprostol, being prescribed with the reversal pills, the oral dose of progesterone, and the vaginal suppository, the on and off switch together. Then there will be a control group, which will consist of women who are just given that off switch and have to go through the current reversal process if they choose to reverse their abortion. This will also be a 4-year study and involve women who will sign a contract agreement to inform researchers of their decision. They will attend ultrasound appointments, and the variables will be noted with this as well. Their pregnancy and birth will be tracked, and the data will be collected and analyzed over all 4 years. So what's the expected outcomes and the impact that this will have? Well, ultimately, this will all lead to more live births. I'm predicting that this is a more effective reversal option. And I'm predicting that this will lead to increased progesterone absorption so that it has a greater chance of outcompeting that mifepristone. I believe that this will change the success rate to up to 85%. I believe it will cause more awareness, and it will be more easily accessible than what currently is out there. I think that with this new process, more lives will be saved and women will get a second chance at choice. I first and foremost would like to thank God for putting people in my life that have made me passionate about this topic. I'd like to thank Dr. Shaw for being my Capstone advisor and teaching me so much about this. I also would like to thank Dr. Abraham for being my Capstone professor. She was very helpful and couldn't have done this without her. I'd like to thank all of my professors for everything they've taught me while being here, and my family, friends, and CNHS for all the support. Here are my references, and are there any questions?
Okay.
progesterone being a suppository, so that is not available right now, I would imagine. How do you think is that going to be prepared to be a suppository?
So it actually is available right now. They have done some prior studies of progesterone being used for this as a vaginal suppository, but alone it wasn't extremely effective, which is why I want to combine it with the oral dose that is and use it together.
Why do you think it would be effective? In what sense?
Yeah. So the whole idea behind it is that we can have more progesterone present so it can outcompete that mifepristone. The reason I chose a vaginal suppository was because in that space, it's so much more highly vascularized and there's a larger surface area, so there can be more absorption quicker. I didn't go with an intramuscular injection or any other form because one, it's a little more user-friendly than an injection, and also it can be done more easily alone than instead of with a medical provider present, as some people would need that for an injection, and it's also cheaper, as a lot of clinics don't have access to that progesterone with them in the clinic through an injection, so this is a little more of a user-friendly option.
So why not just increase the concentration as a suppository
Yeah.
instead of taking a pill?
So what's currently used for this, all those women, is a pill. So I wanted to see if it would be possible to do both together. Yes. Yeah. Yeah, that's a great question. I actually don't, and I don't think they've done a lot with that just because it's tough with pregnancies. And that's actually one of the greatest limitations of this whole study is that with pregnancies and birth, it's so unpredictable. And there's so many unknowns because each woman's reproductive system is unique to themselves. So unfortunately, I don't know of any animal models, but it would be hard to even do it with it since women are so unique in how their anatomy is and how they're made. Yeah. Yeah, absolutely. So when they go to the clinic and they kind of communicate with their provider what they want, we'll then connect them like, hey, if you're wanting a reversal, like this is the process of what we have to do. And then ultimately, we'll ask them to sign a form and they will attend the ultrasound appointments. So the screening will kind of be if the ultrasound if the ultrasound is effective or not, then we'll know that the reversal has worked. And if it isn't, then we'd know that it was not effective.
Another great presentation. Thank you, Alyssa. All right, so on to the next one. This time, we have a presenter. She's graduating with a degree in biology with a concentration in medical sciences. She's from Salinas, California, and has been at SEU for 4 years. She's a very dedicated and focused academically that she made the dean's list and was a member of ACS and SCMDA. Following graduation, she's taking an enhancement year to work as a medical scribe and apply to medical school. Her goal is to become a pediatrician. Please welcome Ms. Evelyn Carranza.
Good morning, everyone. My name is Evelyn Carranza, and today we'll be presenting on the combined therapy of busulfan 1 bacteria and JK2 transgenic mice with polycythemia vera. Now, my interest in finding a more effective therapy for polycythemia vera, or PV, as I will be researching, as I will be referencing throughout this presentation, is not due to just pure coincidence, but rather a personal reason. So in 2009, at the age of 36, my dad was diagnosed with PV. And being 8 years old at the time, it was very impactful to see how he went from being completely healthy to all of a sudden not being able to walk or even stand without the support of a cane. And this was because he had severe vertigo, and vertigo is a condition where you find your surroundings, or feel like your surroundings are constantly spinning around. And he had severe vertigo for several months, and he has also been unable to take hot showers due to the intense itching that the hot water causes him. So after many hospital visits and tests conducted, he was officially diagnosed with PV. After his diagnosis, he has been receiving regular phlebotomy, which is the withdrawal of blood, and he has also been placed on a low dose of aspirin, being considered a low risk PV patient. However, by the age 60, you are then considered a high-risk PV patient due to the age and due to the occurrence of thrombosis, which is blood clotting in the veins and arteries. Now, this is why I chose this topic to see if there's more effective therapy for high-risk PV patients. Now, to find a good solution for this, we first need to understand what is PV. So PV belongs to a group of diseases called the myeloproliferative neoplasms. And what this is when there's an abnormal proliferation of one or more myeloid cell lines. So as you can see on the image, myeloid stem cells result in red blood cells, platelets, and white blood cells. Now, PV specifically targets an increase on red blood cells. And when there's an increase in red blood cells, it leads to thickening or viscosity of the blood. And if not treated, it can eventually lead to heart attacks and strokes. Studies have also shown that PV has secondary effects on white blood cells and platelets as well. So how is PV caused? PV is caused by a somatic mutation on a Janus kinase gene, and also this is abbreviated as JK. This gene is in charge of cell proliferation, cell growth, and cell differentiation. So since this is a somatic mutation, this means that it is not genetically inherited, and this specific mutation, called the JK2V617F, is present in 95% of PV cases. As you can see on the left-hand side, we have the wild type, and this is the normal. And you can see how the receptor is only activated when the cytokine binds to the receptor. This then leads to gene expression, the production of progenitor cells, and the production of normal blood cells. But on the right-hand side, we have the JK2 mutant side. And you can see how even without the presence of cytokine, the receptor is constantly being activated. This then leads to gene expression, the production of more progenitor cells, leading to myeloproliferative neoplasms. Now, PV is more prevalent in males than females, bringing the ratio from 3 to 1 per 100,000 in the population. The average diagnosis range for high-risk PV patients is 60 to 65 years of age, and it is more prominent in individuals with Eastern Europe descent. Some common symptoms of PV include pruritus, which, as previously mentioned, is itchiness of the skin, drowsiness, bloating or pain in the upper left abdomen. This is due to the spleen being located here, and the spleen plays a role in cell control, as well as unusual bleeding. Due to the increased blood cells being produced, it leads to blood clotting and bruising and shortness of breath. Other symptoms, as seen on the image, can also include headaches, blurred vision, and tingling in the hands and feet. So some current treatments for high-risk PV patients include hydroxyurea and interferons. Now, these two drugs are first given to the patient, and when they become resistant to them, then they are treated with a second-line treatment, which is ruxolitinib, and the third-line treatment, which is busulfan. Now, for this study, I will be focusing on hydroxyurea and busulfan. As you can see from the molecular structures, they both have functional groups that carry out inhibitory effects on cell proliferation. So how does hydroxyurea work? Hydroxyurea works by inhibiting the enzyme ribonucleotide reductase, which leads to the depletion of deoxyribonucleotides, and then this interrupts DNA synthesis. Busulfan, on the other hand, is an alkylating agent that works by preventing cell growth by first alkylating DNA, leading to apoptosis, which is cell death. Now, my interest in combining these two drugs together is due to their potential and interactive effects on cell proliferation, also because this will possibly reduce resistance in both drugs individually, and hopefully this will be a better aid for high-risk PV patients. And in this study, we'll be using JK2 transgenic mice because mice are homologous to human genomes, and they can be obtained easily from Jackson Laboratory with the mutation already present, and they are easily obtained at a low cost. So now diving into my specific aim 1, it is to determine the combined effect of busulfan and hydroxyurea on the hematological response of the JK2 transgenic mice. Now, the hematological response is when you bring the cell lines of the red blood cells, the white blood cells, and the platelets going from a high range to a normal range. The null hypothesis is that there will be no significant difference observed between the combined therapy of busulfan with in the transgenic mice and the control group. This yields a prediction that if JK2 transgenic mice are treated with the combined treatment, then the cell production in them will be the same as in the control. So to do this, we will be first obtaining 25 male transgenic mice from the Jackson laboratory, and they'll be male because PV is more prevalent in males than females. They'll be 20 months old because this correlates to the human age range of high-risk PV patients. They're going to be caged, 5 mice per cage, and they're going to be labeled on the ear, as seen on the image, to be able to identify among them. And they're going to be acclimated for 7 days under these controlled lab conditions. Now here's my experimental setup. Groups 1 to 3 will be my experimental, and groups 4 and 5 will be my control. So group 1 will be receiving only busulfan, 8 milligrams per kilogram, 3 times a week. Group 2 will be receiving hydroxyurea, 40 milligrams per kilogram, twice a day, and group 3 will be my combined treatment of busulfan and hydroxyurea with the same amount of dosages. Group 4 will be my positive control group with the placebo, and group 5 will be my negative control group with no treatment. And this investigation will be carried out over 4 weeks. Now, before beginning treatment, we will first need to establish some baseline data, and we'll be doing this by first obtaining blood from the tail veins and putting it into 2 EDT microcontainers. One will be for specific aim 1, which is the blood cell count, and the other one will be for specific aim 2, which is the allele burden. And this will be done simultaneously to avoid further stress on the mice. And the first container will then be sent to ADVIA 120 hematology analyzer, and this will give us the complete blood cell count. And the numbers obtained from there will be input here for the acclimation period. And this is not research I conducted, this is all hypothetical numbers. So since I already have hypothetically done this, here's the number for this. Now for the drug administration, I'll be administering hydroxyurea and busulfan through intraperitoneal injections. And every 7 days, we'll be drawing blood to see the trend of the cell count. And once again, this will be put into 2 EDTA microcontainers. And the numbers obtained from there will be placed here after every week. Now for my specific aim 2, it is to measure the effect on the allele burden in JK2 mice after the combined treatment of busulfan and hydroxyurea. So the allele burden is a ratio between wild type JK2 and mutant type JK2, and this gives the percentage of the allele burden. The null hypothesis is that there will be no significant difference between the control group and the experimental group with the combined treatment. Yielding the prediction that if JK2 transgenic mice are treated with the combined treatment, then the ratio between the JK2 wild type and the JK2 mutant will be the same as in the control. We'll be doing this by first extracting DNA from the leukocytes from the previously drawn blood, and this will be done using Genta Autopore, which is the machine shown here. And then the DNA will be run through PCR-based pyrosequencing. Now here are the individual steps for pyrosequencing. What it basically is doing is taking a single strand of DNA and sequencing the complementary strand of DNA, 1 nucleotide at a time, and determines what base was added. The nucleotide solution is highlighted when it binds to the first unpaired base of the template. What this is doing is quantifying the JK2 mutants against the JK2 wild type, ultimately giving us the allele burden analysis. And here are the hypothetical numbers obtained for the acclimation period. Now, assuming that this experimentation was successful, here are the hypothetical numbers. Once again, I did not carry out this research, so these are all hypothetical. And this was analyzed using MANOVA, which is multivariate analysis of variance. And with a p-value of 0.05, it was determined to be statistically significant. To help you better understand this trend, here is the graph for the red blood cell count. And as you can see from the red line indicated, that's the combined treatment of busulfan and hydroxyurea. And you can see how it has the greatest change among the other treatments in lowering the cell count. And this same trend is also expected to carry out for the white blood cells as well as the platelets. Based off these hypothetical results, I expect for the null hypothesis and the prediction to be rejected. And this means that there was a significant difference observed between the control group and the experimental group, meaning that busulfan and hydroxyurea in combination are effective in lowering the cell production. Now for my expected outcome 2, here is the numbers, the hypothetical numbers once again for allele burden analysis. And this was also analyzed using ANOVA, which is analysis of variance, and with a p-value of 0.05, it was determined to be statistically significant. And here's the graph obtained for the allele burden. As you can see, it went from about 70% allele burden to 0% over the course of 4 weeks. And it also showed the greatest difference between the other treatments. Based off these results, I expect for the null hypothesis and the prediction to be rejected, again, meaning that there was a significant difference between the control group and the experimental group, meaning that the combined treatment of busulfan and hydroxyurea are effective in lowering the cell allele burden analysis. Now, this leads to my future studies, which is to investigate the long-term effects of the combined treatment on the survival rates and the disease progression in JK2 transgenic mice, as well as assess whether the long-term treatment of the transgenic mice will lead to sustained reduction in cell proliferation and allele burden over time. And lastly, to explore the potential mechanisms underlying the efficacy of the combined treatment, evaluating the impact on gene expression and immune responses. I would first like to acknowledge God, because without him, none of this would be possible, and none of us would be here. Dr. Horton for all her wisdom and guidance, because without her, I would know where I would be. Dr. Abraham for being a Capstone professor. My friends and family for their constant love and support and encouragement, and for my peers as well. Here are my references and any questions.
Combined therapy, are you concerned at all that
Yeah, that's why I got the dosages from a specific study that will limit the trend. So it's only going to be given 3 times a week, as if you saw, because it is cytotoxic. So that's something that I took into consideration when I put the combined treatment.
But you see the conundrum, maybe the macro level of down
Mm-hmm. That's a good question. And
yeah, that would be
okay. Yeah.
Okay, so this is not genetic, as we know. It's a somatic mutation. So based from your readings, have you ever come across possible causative factors that might lead to the mutation of the receptors, right?
Mm-hmm.
That will cause this disease?
Well, based on the reading that I did, there have been reports saying that smoking and exposure to hazardous waste do lead to possible development of PV, but this doesn't indicate that it was caused by the mutation. This causes the mutation. So I hypothesize that this is due to the overproduction of the overexposure. The receptors are then become unsensitive to the cytokine, and this would need more further investigation, but that's what I believe. And it is something that I would be willing to look into in the future.
Okay, thank you very much.
All right, another good presentation. So now we are on the last for this morning's presentation, certainly not the least, as you probably have anticipated. Our last presenter for the morning will be graduating also in biology with a concentration in medical sciences. She is from Orlando, Florida, and has been at SEU for only 2 years. Her time at SEU has been spent serving as a site peer mentor, a member of SEMDA, a member of PHSO, another busy one, was a part of honors, the cheerleading squad at SEU, made it to the dean's list, and did neuroscience research. Upon graduation, she plans to take an enhancement year to work as a research assistant for the clinical trials department at LRH, while also applying to med school. Her goal is to work in medical missions. Please give it up to Ms. Catherine Henderson. This on here.
Hi, everyone. My name is Catherine Henderson. I'm a pre-med major here at Southeastern University, and I'll be talking to you today about investigating the link between O-glucan acylation and Parkinson's disease, specifically through the protein parkin, in order to investigate possible new preventative treatments. So to start, what is Parkinson's disease and why should we even care? So Parkinson's disease is the second largest neurodegenerative disease, but it's actually the fastest growing. And we can see that emulated in this graph over here. There are 2.6 million cases of Parkinson's in 1990, and that number increased by 118% to 2015 with 6.3 million. And that is projected to increase even more to 17.5 million in 2040. So with that graph is enough to want to research this disease, but it is also the fact that Parkinson's disease is one of the many NDs that is only palliative care. It doesn't have a preventative treatment, which means the current treatment just looks at improving patient quality of life without stopping the progression of the disease. So it is the goal of my research to look at methods that we can use in the future as preventative treatments for this disease. So a little bit more about Parkinson's disease. It is characterized by the loss of dopaminergic neurons in the substantia nigra of the brain, and that is emulated in this picture over here. I have two pictures of a substantia nigra, the top one being healthy, the bottom one being Parkinsonian, and you can see the diminishing in that black substance, that is the neuronal loss. And that's important to note because the substantia nigra is valuable in your body's movements. It's the connection between your brain and your body. So when we have that impaired, you're going to see a lot of the symptoms I will mention a little bit of Parkinson's. So before we get into it, there are three main other characteristics that are important to my presentation today, the first of which being the increase of Lewy bodies in Parkinson's disease. I know that's a word many of us may not know, so I have a picture of one here. It's a protein accumulation. This is the protein alpha-synuclein. So alpha-synuclein is one of the most heavily proteins when it comes to Parkinson's disease, so it's not the protein I selected for my study. There's also an increase in mitochondrial stress in Parkinson's disease, and that is through the protein parkin, which is the protein I will be looking at in my study. And as we can see here, it is involved in mitochondrial functioning. Lastly, and this one is a little bit more environmental, as while the first two are biological, it is toxin exposure, and this can be through heavy metals or pesticides, and that can be a reason why Parkinson's disease is growing so rapidly, because we have more of that in our society today with increasing industrialism. Moving along, some of the most common symptoms of Parkinson's disease. I mentioned earlier the substantia nigra is what is impacted, so we can expect to see motor symptoms such as bradykinesia, which is slowness of movement. We can see postural instability, rigidity, and tremors. And in some cases, but not all, we can also have an inclusion of non-motor symptoms. This can be anything from dementia to sleep disruptions, olfactory changes, behavioral changes, anything non-motor is collected over there. Now, some of the current treatment, this cycle is a great example of what a Parkinsonian patient could expect. We begin at the top at A with rehabilitation. This is an optional treatment because it is mostly done with Lee Silverman voice treatment, so not all Parkinson's patients will struggle with this, so not all will opt for it. Most cycles start at B with drug therapy, and this is through dopamine replacement, which we can understand because of that loss of dopaminergic neurons, and this is usually through the drug L-DOPA. Continuing along, there are more holistic measures such as aerobic exercise, and when studied with Parkinson's disease, it was shown to improve cognitive functioning. And as we continue around the cycle, you can notice that this is growing more in the maintenance area because the symptoms of Parkinson's disease grow more resistant to treatment as the disease progresses, which is really important to note because we need those preventative measures to stop this progression. Lastly, a Parkinson's patient can opt for surgery such as deep brain stimulation. That is important to note because it has severe adverse effects such as dyskinesia, which if we don't know is another movement disorder, which you can understand why a Parkinson's patient wouldn't want more of that. So this leads me to what is O-glucosination. So O-glucosination is commonly known as O-linked beta and acetylglucosamine, and that is a large word that can tell us a lot about what it does. So that is a post-translational protein modification that works through glycosylation. So that last part, acetylglucosamine, that signals to us that it's a sugar, and it occurs on serine and threonine residues of your target protein. So I've put up another image of my protein parkin, and this is a chimera picture of this, and so I highlighted in blue and purple the serine and threonine residues of parkin to demonstrate that this isn't just a random protein I'm picking, but it can be used to study O-glucosination. A little bit more about the mechanism of O-glucosination. Beginning at the top of this figure, we can see UDP-gluconac is the starting substance from the hexosamine biosynthetic pathway. That's important to note because it shows the involvement of glucose dependency and insulin resistance in not only O-glucosination, but neurodegenerative diseases, even besides Parkinson's disease. Continuing along, the enzyme OGT is what is called O-gluconac transferase. It's what's going to add O-glucosination onto a protein. And continuing along, OGA, O-gluconate-ACE, strips it off. And those two enzymes are going to be very important for my research to be proposed soon. So the main function of O-gluconate involves the protein's stability, integrity, localization, and activity. And with these in mind, it can be understood that when Parkinson's was studied in diseases such as Alzheimer's, when there was an increased level of O-gluconate, there was a decrease in harmful tau, which is a protein involved in Alzheimer's aggregation. And this was studied once more in Parkinson's disease, and it was studied with the protein alpha-synuclein I mentioned earlier. And we saw that an increase in O-gluconate led to a decrease in alpha-synuclein Lewy bodies. So this suggests a neuroprotective role of O-gluconate in neurodegenerative diseases. So it's the purpose of my study to look to strengthen this link by asking the question, can we look at O-gluconate with a less studied protein in Parkinson's disease, such as Parkin, that way we can option clinical trials in the future. So I will do this through two aims, the first of which looks to investigate the phosphorylation states of Parkin in a mouse model to see the impact it has on O-gluconate levels when they are increased. The hypothesis is that when there are increased O-gluconate levels, there will be a decrease in Parkin phosphorylation. And what that means is it will stimulate, again, a neuroprotective effect like the ones we saw in previous research. Before I get into my methods, I want to talk about a few procedures that will be used through this, the first of which being a TET on-off system. This is a way we can inducibly change gene expression. And this is important because I will be using the gene OGA to be manipulated. And when the system is TET on, OGA will be expressed on. And that's important to note because that will mean that there will be normal levels of O-gluconate taking place. And that will be triggered by the introduction of doxycycline. And when the system is TET off, OGA expression will be off, and we will therefore not be able to strip off O-gluconate and will have increased levels of O-gluconate in our mouse model. And that can be triggered by the absence of doxycycline. So this will be analyzed using a Western blot, the purpose of which is to identify protein concentrations in a tissue sample and look at how their prevalence is. And this is a whole long drawn-out process that takes about 10 hours or more if you have the equipment that we have. And it is basically just gel electrophoresis followed by antibody washes. My experimental group will have 10 male mice, all TET off for OGA. So if you remember, that means that OGA expression is turned off, so there will be increased levels of O-gluconate. And we will do this by triggering them with off of doxycycline for 3 days. They'll be sacrificed and homogenized for the substantia nigra tissue, and then I will conduct a Western blot analysis. I will emulate this one more in my control group with 10 male mice, TET on for OGA. They will again be kept on doxycycline to be TET on, sacrificed and homogenized, and a Western blot analysis will take place. So the expected outcomes that I'm seeing, I hope to see, is when there is an increase in O-gluconate levels in that experimental group, we will hope to see a decrease in Parkin phosphorylation. And that will signify a neuroprotective effect of O-gluconate as has been studied before. In my second aim, I hope to investigate the levels of O-gluconate in a Parkinson's disease model. This is different from my first aim because I will not be doing a TET on-off system. I will simply be investigating the levels of proteins in a Parkinson's mouse. And I'm expecting to see that there will be a decreased O-gluconate in the Parkinson's disease model as compared to the healthy control. Now, it's important to ask, what model am I going to use? I'm going to use the methylphenyl tetrahydropyridine. That's a mouthful of a word, and it basically means that it's going to model Parkinson's disease by modeling oxidative stress and mitochondrial dysfunction, which is a great option for my study since the protein Parkin has that function in Parkinson's disease. It easily crosses the blood-brain barrier, and it can replicate Parkinson's symptoms and has been shown to do so. I will also be using co-immunoprecipitation, which basically looks at protein-protein interactions with another series of antibody proteins, and it will be looking to see if a certain protein, in this case Parkin, will pull down with other proteins, in my case during a Western blot analysis. My experimental group will consist of 10 male mice, all MPTP for Parkinson's. They will have a series of 3 Western blot analyses, and the first of which looking at O-gluconate, then OGT, that other enzyme involved, and OGA. And this is just to get a glimpse of what the role of these proteins are in a healthy model and a Parkinson's model in this case. In each case, I'm going to have to strip the antibodies afterwards so we can run the Western again. This will be again done in a control group, this time with healthy mice, 10 male as well. The same 3 Western blots and the same stripping of antibodies, and in both cases, there will be a co-immunoprecipitation to see if Parkin will pull down with any of these 3 proteins. Specifically, I'll be looking at O-gluconate. So I'm expecting to see that when there is less oglutenacylation, it will be in the experimental, showing that the disease model has less of what I hypothesize to be a neuroprotective modification. I'm also looking to see a pull down of Parkin with oglutenac, which will further strengthen the case that the two are connected. This will not only look at the neuroprotective, but once again, the link being strengthened. In future studies, I look to examine the role between the PINK1 Parkin pathway and oglutenacylation, but more importantly, I want to look to see if we can option clinical trials with drugs such as Thiamet G, which increases levels of oglutenacylation in the body and can therefore be used to investigate the use of oglutenacylation, not just as a use for mice to see if it'll enable Parkinson's protection, but also in humans. I want to acknowledge God for even bringing me to Southeastern, all of my family and friends who are here today. I would like to thank all of my professors for even giving me the knowledge to be able to present this, and Dr. Franklin, my advisor, for teaching me so much about research and life, and I would not be the person I am today without you. And these are my references, and any questions? Yes, so I saw that Parkinson's disease, it is connected with alpha-synuclein with oglutenacylation, and that's what's been most heavily studied. And in most cases, it was only looked at through that lens, which is why I selected Parkin. And there haven't been many studies conducted specifically using treatments of oglutenacylation, just the inducible gene expression changes or even gene mutation changes. So that's why I wanted to option clinical trials such as Thiamet G to see if we can use treatments to see if that'll change. Okay. So I haven't seen any of that nature specifically, mostly because the treatments are palliative at this point. So it's kind of hard to gauge how that would change. But that would be a great option for a future study. Yes. So yeah, by emulating the neuroprotection, I'm looking to see a decrease in the phosphorylation of Parkin and the amount of it in that Western blot as compared to my control. And that would signify a decrease in activity. And that decrease in activity would suggest neuroprotection because of the role of Parkin in Parkinson's disease when it's unmodified.
So to your doxycycline experimentation,
Yes.
I didn't get that. Are you using a healthy mouse in that? Or are you using
Yes.
actually, so you're using,
Yes.
yeah, healthy.
So
So that's where I'm kind of lost.
Sure.
So are you inducing the Parkinson's in that instance?
So in this case, I'm using healthy mice and inducing gene expression to increase oglutenacylation. It doesn't have an affiliation with Parkinson's disease, just a Parkinson's protein, to see if oglutenacylation can be connected to that protein. And then it's my second aim that looks at Parkinson's mice to see if we can have oglutenacylation present in those mice. So in future studies, I can look if, or even if I had a third aim, I can look at those MPTP mice with increased oglutenacylation.
So is your assumption that the healthy mouse and Parkinson's suffering mouse is exactly the same possible response?
No, ma'am. I know that they're going to be completely different. I'm just looking to see how a healthy Parkin will react to increased oglutenacylation so we can have a baseline to then further look at trials and studies to see how a diseased mouse with diseased Parkin can be impacted by oglutenacylation.
No question.
Thank you so much.
Thank you so much for coming. We'll be back here, I think, at 1 o'clock, right? That's just wrong. So thank you, everybody. There will be another more of the good presentations in the afternoon. So please come back. Oh my gosh.